Good morning to everyone. Thanks for joining us. My name's Corey, and I'll be the moderator for today's webinar. We're excited to talk about our chronic care management solution and some of the benefits and challenges that we face, what we see with CCM, and the reimbursement changes for 2022. And then our solution to make CCM easy to adopt and profitable for your practice. Just a few housekeeping items. The webinar is expected to be 30 minutes. We'll be about 20 minutes of presentation and we'll have time for Q&A at the end. We are recording the webinar. We will be sending slides and the recording to you after the webinar. Everyone is in listen only mode, but if you do have any questions, feel free to use the chat to submit any questions at any time during the webinar, and we can cover those at the end of the Q&A time. Tina is going to be our presenter today. She has over 10 years experience advising practices and health systems on how to leverage technology to impact patient care and financial sustainability. She is Health Prime's Vice President of Business Development and Specialty Markets and also works as a registered nurse in critical care modalities. So I'm going to turn it over to Tina for our presentation.
Hello, everyone. Thank you for joining today. I appreciate you taking some time out of your day to listen to our presentation. So I want to just start off with chronic care management programs. A lot of people hear that, CCM, chronic care management, right? So there's care management programs out there that are specific to more social type work, and chronic care management does cross that line a little bit. So we want to talk about really what the program entails and what you have to do to be successful under the NEM coding. So it's a reimbursable non-face-to-face medical service that adds an extra layer of patient care for most vulnerable patients. Those are the patients with the chronic illnesses. Those are your patients that are continuing to go to the ER or being hospitalized. One of the main diagnoses that I think of in this patient population is congestive heart failure patients. We know that managing those patients can be very brittle, and there's different, things that can send them to the hospital. Different diet, medication adherence, exacerbations can be very easy, especially certain times of the years around the summer. Watermelon, people love watermelon. They eat a lot of watermelon. They increase their water intake. So this is just looking at those patients with those type of illnesses, any illness that really can get them hospitalized within a 12-month calendar year. So why would you want to put this program into place? That's something we keep thinking of. As an overview, the requirements are you have to have patient eligibility. That patient has to have those two disease processes that, fit in the category. Does CMS give you a defined diagnosis code list that you can choose from? They do not. So thinking of that we want to make sure that we're looking at the patient population and looking at those eligible disease processes and how it impacts the patient. The requirements, patient eligibility, the CCM requirements, you have to have, be working in a EHR system, you have to have acceptance by the patient, you have to provide a care plan, update the care plan accordingly, give goals, and they need to be patient-driven goals, not goals where you tell the patient, you and the patient need to come together with some patient-driven goals. And there's patient challenges in a CCM program. There's practice challenges in a program, and we'll go over that in this webinar. Some of the facts at CCM that is that 99% of Medicare spending is on patients with chronic conditions. Those are the patients who, again, frequent the ER, have high admission rates, and overall do not participate in those social determinant of care programs out in the communities. 2 out of 3 Medicare patients have 2+ chronic conditions, and chronically ill patients receive 56% of recommended preventative care. So there's a gap in that care there too. So another place CCM can help you fill in those gaps and the voids in the care model. Moving on to our next slide. What is the benefits of having CCM? Well, number one, patient care, right? We're all come into medicine wanting to take care of patients. We want to impact patients' lives. how does the patient benefit from it? They get more support at home, right? So you have a nurse who's reaching out to the patient, or the patient can reach out to, that is interacting in the care, helping the patient to become more more active in their own care model in their home. Once they get outside the four walls of the practice or the four walls of the hospital, we do have to help them be successful in their community. Interventions avoiding. We want to intervention avoiding. So we want to make critical health events. We want to make sure that we're not, as we're teaching the patient and we're giving these patient these different things to do in the home to help. When you think of a person with COPD and they have trouble breathing, teaching them about the tripod stand. So if they can do a tripod stance, then maybe they can relieve that exacerbation in that moment. And it's not really an exacerbation, it's just a temporary symptom that they're having from their disease process. We engage them in the care plan, and we encourage them a sense of responsibility by giving them that care plan. We're saying this is the for your hypertension, we're going to focus on your diet. The DASH diet is what we all know, our 2-gram sodium diet, that we want patients to adhere to. So we provide not just the teaching, but we give them tangible resources they can, read, reflect to, and then we get feedback from them. Keep a food diary. Let's talk about what you're eating. Sometimes people don't notice the natural sodium that's right there in a tomato. So they are not counting that as salt. They're counting the salt they're putting into things. We educate them on the condition. We want them to understand the physiological part of that condition and how it's impacting their body. But we're doing that in layman's terms so that the patient has a better understanding. We want to reduce the medical expenses. We know that there's a huge healthcare burden in the medical sector right now regarding the readmission rates, right? And it impacts the payment to the hospitals and the physicians when we have readmission rates, but it also impacts the patient, right? Patients are missing, if they're still working, even if it's part-time, they're missing days at work. Those medical expenses are, they're having to make a choice. Do I buy my medication? Do I pay my copay or pay my hospital bill? And we want to help them manage the medication. Medications can be extremely confusing. When we go to a doctor, sometimes, the doctor has 15 minutes from the time that person enters the practice to the time the patient leaves. That's the typical time. Not saying that we don't have providers that spend more time, but medications can be tricky for some patients. They go home, they've had changes, they don't really understand, or maybe we used the brand name and they are using the generic name and they don't realize to stop the medication, and we create another event that drives the patient to the hospital. The practice benefits is we're going to improve the patient outcome, right, with the care plan adherence. As we're working through that with the patient, we're teaching them the strategies to be successful at home. We're also, keeping the patients out of the ER, keeping the patients out of the hospital. We're really working on our utilization scores, where we can go back to the payers and say, we have programs in place and we show that we have improved our utilization scores, and therefore we can negotiate better payer contracts. We reduce burnout on our staff in the practice. The staff is consistently answering phone calls, consistently medication refills, all these different things. And a lot of practices have had to put policies in place, like your medication refill will take 72 hours. When you have a chronic care management nurse, that nurse can help bypass that 72 hours, take that task off of that the MA or the nurse in the practice, or the physician. Sometimes physicians don't have nurses or MAs to do that and they're doing it themselves. So it helps reduce the level of responsibility on the practice or of specific people in the practice to help reduce the burnout. And improves the patient engagement and satisfaction and loyalty. Patients really feel like you're engaged in their health when you're having these programs, because you've got someone consistently working with them. And when they're talking to their friends, they're like, I go see Dr. Smith, and Dr. Smith put me on this program, and I have a nurse that reaches out to me, or I can call them if I have a question, and I don't have to wait till my next visit. So the patient's engaged, the patient's happy with the service that you're delivering, and the patient's loyal. They will continue to come in to see you. If patients feel like they're not getting the level of care they want, they will find other providers to go to. And obviously, it adds a reimbursement opportunity to the practice. We are all working on very tight budgets. We have the opportunity to get paid for something you're probably already doing to an extent, if not fully doing in your practice that you're just not following the documentation trail to get the reimbursement. So increased reimbursement allows us to increase our staff. It allows us to bring other programs into the practice. Again, that impacts the patient outcomes. Next slide. So what changed in reimbursement this year? So a couple things, right? On the 99490 and the 99439, those are going to be your non-complex care codes. They increased significantly. The 490 by $20 per patient per month, and the 493 by 10. So $62 per patient per month. And I remember when CCM first was initiated and put out into practices, some practices were getting paid as little as $27 for this service. So it didn't really make sense, because when you're paying staff to manage this program in your practice, you have to at least be able to break even on, the revenue that you're spending. The 99487 and 489, which is complex clinical CCM, was increased to 132 and 70. So $39 increase, $24 increase. That's significant. CCM overall was increased by about 25%. And then you have provider-based CCM, which really is not as, I would say I don't see that in a lot of practices. It's where the nurse practitioner themselves or the provider themselves is completing the CCM program on the 491 and 437. Those didn't really, the 491 didn't really change. The 437 did, was an addition, and it was an increase. So non-complex coding has the highest reimbursement rate, right? So it's 156 versus 132 if you were doing, if you look at a complex patient. Sometimes you do need to roll that patient into the complex model because they're having a lot of issues. The complex model does have to surpass the 60 minutes, and there has to be a level of the physician engagement in the patient plan higher than you had at the non-complex level. And then just making sure that you're documenting the verbal consent. I like to, every time we talk to a patient, we like to get verbal consent again. We have a place in our software that we check that we've reviewed the consent again and everything that's involved. And there's certain highlights you have to hit with Medicare, that they consent to be part of the program. They understand there can be a copay, and that they consent to continue to receive treatment. And you got to document the interactions, document the care plan, and documenting the time, right? That's critical, because that is really the elements that you need to be able to build this code. So moving forward, revenue examples, and this one that we did illustrates a minimum non-complex CCM service provided to your patients, and it's just 20 minutes per month. And 100 patients at the $62 brings an additional $74,400 of revenue to a practice. That's pretty significant. But if you go to 150 patients, you're looking at $111,000, and 200 patients, you're looking at $148,000. So the reason why I say that, that is significant, Medicare, usually in a Medicare population, a physician who manages Medicare patients, whether that's managed care plans or, straight Medicare, normally will have 250 to 400 patients per provider in the practice who qualify for this. A lot of these patients also have had previous employment, some military communities, and they have a secondary insurance, so the copay no longer becomes the issue. And these are services you're providing to your practice, through your practice, to your patients in an extent, and you're just not being reimbursed for right now. Next slide. How do we help take the burden off the practice? I'm going to move forward. So when I came to Health Prime, back to Health Prime, I've been with our family of businesses for about 6 years. One of the things that we really recognize in the revenue cycle management world is value-based care is really starting to drive healthcare, right? So we might not be practicing in a value-based care setting currently, but that is where value-based is, where everything is going in that value-based setting. So we looked at what can we offer. We had lots of our provider saying, I really want to do this and I feel like I'm doing this work, but I'm just not getting reimbursed for it. So we put together 100% managed care CCM. We have licensed certified clinicians, LPNs and RNs. We have a 5-star service. We follow our white glove model that we provide for RCM services. We want to have that in everything we do. It reduces the strain on the office between the visit and the tasks that come in between. And we have proven reimbursement success. And there's no upfront costs to the client to initiate the service. And what do? We're essentially giving you a nurse. The nurse works remotely. We send out some information introducing the nurse that we work in your practice that you can hand to the patient. This is going to be the nurse. They work from our practice remotely. They'll be reaching out to you to go over the program, and they'll be following you out the program and working with me to ensure that we're delivering great care to you. So we help secure the CCM reimbursements. We are identifying eligible patients for you. We don't like to go into the system and pull a list and say, we're going to call the patients and tell them that you want them in this program. We like to look at the schedule for the week, look at your patient population, see what patients actually qualify and would benefit from the program. You can have a patient who has stable coronary disease and stable hypertension and enroll them in the program, and they're not going to benefit from the program if they're not having issues. They will not be as compliant in participating in the program as a patient who's like, I just really having trouble getting my blood pressure under control. My blood sugar continues to stay high, those types of things. So we give you that list as the patients are coming in. We want you to be able to have the conversation. Hey, I have this program I'm starting, and I really like for you to enroll. Robin is an extender of my team, and she's remote, and she'll be reaching out to you. We find that there's better compliance in that model. We establish the care plan for you, right? So that's the biggest thing that people do not have time for, establishing that care plan and making sure that the care plan fits the Medicare guidelines. We do the monthly review and follow-up. We have during your normal business hours, they're able to reach right out to our nurse. Our nurse will triage them, work through what's going on. If they need to be seen by the physician, we're going to reach out and try to get the patient into your office because we don't want the patient going to the ER. That's exactly what this is hoping to prevent. However, there are times when those patients will exacerbate and will need, emergency intervention. And then we help do the billing for the CCM services as well. So, and then again, reimbursements come in the door, and it's just this continuous cycle that takes the workload off of your practice. Your care team is extended. As I was stating, our nurses really do want the feel of being part of your practice. We interact with the appropriate people who are identified at the practice, but we really do like to have maybe some practice time where we can do a Teams meeting and meet your whole staff so they understand who the person is, who they'll be working with, and how we should work with each part of the practice. We offer that care plan support. Again, that's like the biggest bottleneck for some people in practices to get this program off the ground is building the care plan, reviewing the care plan, and updating the care plan appropriately, and knowing when someone reaches one goal that we can identify another goal to keep on the care plan, but you want to make sure that you're working with that patient and these are obtainable goals so that if and when it ever happened, you had a Medicare review, that you have the evidence-based practice behind it. We work on the prescription management. So every time we talk to a patient, we are reconciling their medications in your EHR system. Reconciliation of medications, we all know, is a big MIPS measure that a lot of the practices utilize to be able to hit their scores. So we're helping drive other revenue factors in your practice as well. We also are looking at the care coordination of if they need a refill, we can put in the request to the practice. The practice then just has to send the refill out. In some models, we have had where we send it directly to the doctor. Sometimes it's the nurse or the MA that actually refills certain prescriptions and certain classes of medications. And it kind of leads back to that care coordination where we're supporting that preventive care and transition care between settings. And the other thing that we like to do in that care coordination model is we want to read the patient's chart. We want to make sure that we talk with you guys about parameters. Like we have a patient who's diabetic, their hemoglobin A1C hasn't been done in a year, so let's get it done every 6 months. We're going to encourage that patient to go out and um, get their hemoglobin A1C. We're going to let the practice know, hey, Mr. Smith is coming in, and we see he hasn't had a hemoglobin A1C in 6 months. We also want to look around flu season, encouraging patients to get flu shots who are eligible for flu shots, shingles vaccinations, COVID vaccinations, all these things that are coming into play. And especially talking about these vaccinations and bringing up COVID, in the world of COVID that we've lived in the past few years, we have a lot of patients who have long hauler symptoms that have come along with COVID. And so these are all new diagnoses on top of what they're already experiencing. And we want to make sure that we're giving them the information relevant to their area and how to take care of themselves. Moving forward. It's easy. Our program is incredibly easy to adopt. So we look at enrollment. That's just once we have an enrollment, you say, hey, we want to enroll XYZ. We set up whatever tasking model works for your practice. We would get consent from the patient. And we want to do that by, again, identifying the things that Medicare requires you to identify to get consent. So the patient it's an informed consent. And we update that again every month. We do the initial intake and we build our first care plan. We're talking with the patient, we're identifying where the care gaps are, where the education gaps are. We're gonna do some education there. We're also working to identify other practitioners that the patient may be working with in the community so that we can facilitate sharing the care plan in between those specialists to make sure that everyone's on the same page of what's going on with the patient. We do the monthly review and support. The nurse is contacting the patient for those 20 minutes a month. Those 20 minutes a month do not have to be delivered all at one time, and they don't actually have to be a full 20 minutes of direct contact with the patient. It can be any type of task you're working on to help the patient. So we are documenting as we're doing that. Our software has intuitive timer that we're turning on and off at each interval that we're working on the patient to make sure we're capturing that. We can do calls, the care coordination, the medication management, all part of that. And of course, the reimbursement. We need to bill and collect for what we're doing, right? So we're going to look at, we've met all the elements for the code. And depending on what the workflow is that we determine with the practice, we can go in and we can create the encounter and we can help you push that CCM code out every month. We have a quality assurance plan here. And what we do like to do is I have all CCM in the beginning till we make sure we have 100% accuracy, which we've never missed. We have our quality control team of coders go through, review the visit, and review the documentation to make sure we have met all the elements before we push that code out. So why would you want to do this now? We all know that there is definitely limited resources. A lot of practices are struggling to get people hired, to keep people on staff. I think the 2 years that people were working remotely, or the 2 years that people were working in healthcare and have unfortunately decided to leave, has really created limited resources and practices. We want to increase your patient outcomes. You have a dedicated team that's going to support your patients, personalized needs and care plans, and help get them elevate their own responsibility in their healthcare, as well as communication with the practice. Patient engagement, the patient is going to be more satisfied. The patient is going to feel like we really, really have an interest in what's going on with them as an individual. Practice growth. This is just, again, revenue. It's a way to expand your practice, a way to be able to have additional revenue, to look at new service lines that you could put into place in your practice, hiring that extra MA that you've been needing, getting a phlebotomist so you can do labs. So however you look to expand what you're doing in your practice, you always need revenue to do that. We're going to reduce the strain on the staff. We're going to, take some of that workload off of them by being able to communicate with a designated team, with your patients on what the things that they need to do. Some of the phone call burden that your staff is receiving now, we'd be able to take that off of them. And we're really helping you in this program. And I think everyone's trying to help everyone right now. And we're seeing this shift to value-based care. Chronic care management is a really good program to put in place to help you start thinking on bridging the gap between, fee for service delivery and value-based care delivery. And it helps you look at, when you're deciding to go into value-based care contracts, how you score your patients with these chronic conditions and the amount of time it's taking you to deliver care and keep the patients healthy and safe. So that's that hierarchical scoring you have to do in the managed care world. And next slide. So the next step is, let us support your CCM goals. Robin Wisniewski is a certified, she works on my team. She's the lead care manager of Health Prime. She's nationally certified managed care nurse. Myself, I'm a registered nurse, again, vice president of business development, specialty markets. And even if you're gonna say, I'm not real sure if I want to outsource this to someone, but I do have questions, we are more than happy to spend time with you, answer your questions, help you make determinations of where your practice can go with chronic care management. And now back to you, Corey.
Thanks, Tina. Thank you to everyone for participating. We are going to answer any questions that you have, so feel free to submit those in the chat. Please feel free to take down this information. We will be emailing it out as well with the slides, so you can reach out to Robin and Tina. They're an excellent resource, and they really do have a passion for supporting practices, so please use them as a resource. And we are always available to continue this conversation offline. So if you think of a question, you don't have any questions now and you think of one later, you're definitely able to contact us. So we do have one question right now. The question is, Tina, is this meant for only primary care or for specialists as well?
Absolutely not. This can be done in any type of practice, just as long as the patient meets the criteria. We just want to make sure when we talk to the patient that they're not enrolled in another chronic care management program, maybe through their primary care doctor. But I see this done a lot in endocrinology, cardiology, neurology, pulmonology, women's health, as it's become really big in women's health around hypertension. So no, any specialist can do this. And I think that's a great question, because I think sometimes people do believe that this program is limited to primary care. But the specialists, you guys really do deal with a lot of the diagnoses that do put the patients back into the emergency room or the hospital setting.
Another question for you, Tina, is who covers malpractice for the nurses?
We have our own malpractice insurance policy at Health Prime, but the nurse is working with the physician, intimately with the physician, and taking direction from the physician. So there would be some level of responsibility on the physician's part. That's why everything we do goes into review for the physician. We'll need to say they reviewed the care plan and they agree with what we're saying before we send it out to the patient. So we are working with a physician or the designated, maybe nurse practitioner or PA in the practice, to make sure we're delivering the quality program that the practice wants.
Thank you. Another question is billing. How is it billed under? Is it billed under our nurse practitioner or under their physician?
So it can be billed under a nurse practitioner or a physician. It actually can also, by the guidelines, it's a pretty expanded types of practitioners. Pharmacists can bill for chronic care management, social work can bill for chronic care management, but a lot of practices will set up a point of contact being with like a mid-level provider, the nurse practitioner or PA. That way, it does take a little burden off the physician. But it's really based on how you want to structure your practice. The physician can be involved or the mid-level.
And then a specific question about coding is the 99491, 99437 only for NPs and providers? I think that was
the provider-based chronic care management. Yes, that would be a provider or a nurse practitioner would have to be engaged throughout the whole delivery of the allocated minutes with those codes, so that you could bill that code itself. We see that is probably the least used codes in a practice, because the reimbursement is so much lower than if you actually just did non-complex care. But the physician would have to initiate the care plan. The physician has to update the care plan. There has to be documentation in the EHR system of when you're looking at complex care, physician-based care, of what the physician is doing that would be specific to a physician to drive that care.
Thank you, Tina.
Welcome.
Tina, when you're discussing with physicians and administrators, what do you feel is the leading driver behind CCM adoption? What's making them take that step in deciding to adopt the program?
I feel it's the patient outcomes, right? And the level of the care they want to provide to the patients. Patients going back to the ER, we're really vested in good patient outcomes. No one likes a poor patient outcome. So I think that that is something that has really been driving this. A lot of hospital systems are also adopting chronic care management and remote patient monitoring because the impact financially to them, right, for that readmission in the next and within 30 days, let's say for CHF, that is impacting the revenue, but it's also impacting the patient outcome. What's the gap that we have there that the patient is leaving, going home, and not necessarily what did they not understand, or what in the social determinants of care are we missing that we're not able to close the gap for the patient? And that's a lot of people will look to TCM for that, transitional care. And transitional care is a great program if you can capture it. Sometimes the communication between the hospital and the physician's office may have a gap in it, and you miss that, 7 or 14-day window. And maybe the patient doesn't call as, I know as a nurse, when I discharge patients, I say, I've made this appointment, or I was not able to get in touch with your provider. You need to call your provider in 1 to 3 days to see the provider. But sometimes we lose that in translation, or the patient loses that in translation because they've had a life event. They've been in the hospital, and then they get home and everything's so hectic. So a lot of hospital systems started initiating some of these programs, even if there is a payment model for health systems, but even if they're not getting paid on it, they're seeing that the impact it's making on not having the readmission rate.
And I'll say, as a patient and with other family members, I've seen that as well. I had a family member that was offered a study from a hospital post-surgery to utilize remote patient monitoring and have that access to the nurse. And so I know hospitals out there are looking at comparing the outcomes with patients and these programs. So it's exciting to see. And, as a caregiver for that family member, it was a great resource to have. So I'm thankful that technology is helping us push outcomes along.
And I think that's something we saw during COVID. The hospitals were burdened. We didn't have beds. We didn't have emergency room capacity. And a lot of places, I know a really good example was in Mississippi. The health department adopted this RPM program where patients who thought they had COVID tested positive, they couldn't get into a hospital system. They deployed remote patient monitoring and chronic care management services to those clients, our patients, however you want for, health system, it's the patient, but out in society as a client, to attract the patients to see, like, at what point do we have to find a place to put this patient because they're obviously decompensating. So I think COVID really pushed the envelope for us on remote patient monitoring and on care management, right? So it's exciting to see that how we're adopting these two programs across the board, because patients, they deserve the access to be able to try to manage this from home if possible, and to be independent in their care.
Definitely. Well, thank you so much, Tina. And thank you for all of the attendees that joined us today and the excellent questions. We look forward to continuing to discuss with you offline. Feel free to reach out, and we'll be sending out a recording of this webinar once it is available. And we'll also be sending you the slides as a resource.
Thank you guys all so much. It was great being on this webinar with you today.
Thank you so much. Have a good day.
Bye, guys.